start now. So we are very glad to welcome you to this webinar series for Latin America and the Caribbean on nutrition in emergencies in the context of COVID-19 and migration, organized by the Regional Office of UNICEF for Latin America and the Caribbean and the Global Nutrition Cluster Technical Alliance. Today's webinar is about the prevention of malnutrition in children under 5 and the context of COVID-19 and migration, with a focus on infant and young child feeding and supplementation. Okay, so I introduce myself. For those who were not here in the last webinar, I am Yvette Foch, nutrition specialist at the UNICEF Regional Office for Latin America and the Caribbean. I am also the migration focal point at the Regional Nutrition Coordination Group and the nutrition focal point for the Regional Migration Response Plan of the R4V platform led by UNHCR and IOM. Caroline de Hilary will also be with us today as a facilitator. She's a family physician and a public health specialist from Save the Children. She's based in Bolivia. And we will have Geraldine Belloc and Ben Allen as technical support. So just before starting, I would like to mention that this webinar is being recorded. So any intervention you do in the chat or in the questions and answers will be recorded. Also, there will be 2 knowledge tests, one before and one after the webinar. This is confidential, so nobody will see at your specific responses. So feel free to participate. At the end, we will have a Q&A session to reply to the questions you may have. And we will also have an evaluation of the webinar. So before leaving the webinar, we invite you to reply to the questionnaire. Now I leave the floor to my colleague, Caroline.
Hello, good morning or afternoon, wherever you're calling from. As said, we know each other from last week's webinar, but if this is the first one you're joining, just to let you know, we are also sending out links to the YouTube recording and to the presentations after this webinar. I'd like to go right into the poll. I'll give you guys 3 minutes. Please answer. Everybody who is participating, just put your answers. We will not see your names attached to the answers. Anybody joining this webinar, please fill out the poll, which is kind of like a pre-test thing. Okay, I will stop the poll now and show you the results, but I won't comment on them because we're having the same questions at the end of the webinar, and we hope that at the end of the webinar, the answers will have become clear through the presentations and questions and answers. I will just show this, and I hope my colleague Geraldine could take some pictures. And I will now stop showing these results and go right into the webinar. Next slide, please. So the content of this presentation is divided basically into 4 chapters. I will take you through the first 3, and then my colleague Yvette will take you through chapter 4 and 5. The first ones are, we're going to start off with the adequate infant and young child feeding practices and their importance, to then go into what happens if these IYCF practices are inadequate, so if they have some consequences. And we'll talk a little bit about the impact of emergencies on infant and young child feeding. As I said, the 4th chapter will be led by Yvette Fauch, who is going to talk about the interventions that are recommended to prevent infant and young child malnutrition. Next slide. So about the adequate infant and young child feeding practices and their importance, next slide, we'll be talking about the 4 practices that are recommended, which are immediate breastfeeding, exclusive breastfeeding, prolonged breastfeeding, and complementary feeding. The next one. So why should we practice or promote immediate breastfeeding? And what does immediate breastfeeding mean? We had a question about that in the poll. Immediate breastfeeding means breastfeeding within the first hour of life. As it says here, start breastfeeding within 1 hour of birth. And there are some studies that indicate that the risk of death in the first 28 days of life, so neonatal mortality, is 48% higher if the baby has been fed during the first day, but not in the first hour, and 79% higher if the baby has been fed after the first day, compared to those newborns who were breastfed in the first hour of life. So early initiation of breastfeeding can avoid death or contribute to avoid death during that very vulnerable moment in life. And it is particularly related to the success of exclusive breastfeeding. So if a mother has started to breastfeed within the first hour of birth, she's more likely to be able to sustain exclusive breastfeeding, which is the next slide. So what does exclusive breastfeeding mean? It means not giving anything else to infants 0 to 5 months of age other than breast milk, no other liquids, no other foods. And we have some statistics here. So children who are not exclusively breastfed are 14.4, or no breast milk at all, excuse me, are 14.4 times more likely to die. If they receive breast milk and other milk, what we call mixed feeding, they still have a higher risk of death, which is 2.8 times And if they receive breast milk and water-based liquids, like water or juices or tea, they still have a higher risk of death, 1.5 times higher risk of death compared to babies who are exclusively breastfed. Now, which diseases are we talking about? Particularly pneumonia, but also other respiratory infections and diarrhea. We know that better breastfeeding practices could prevent half of the diarrhea and 1/3 of respiratory infection episodes in children. That's quite a bit. And we also know that exclusive breastfeeding improves cognitive skills, which we will see later on in the baby, but it is at this time of life that actually the neuronal connections, the synapses are developing very quickly. Exclusive breastfeeding is also good for the mom. It protects the mother from breast cancer, ovary cancer, and type 2 diabetes. And very importantly, it delays ovulation. So the return to fertility after giving birth is quite effectively delayed while she's exclusively breastfeeding. Whereas if she is practicing mixed feeding or not breastfeeding at all, she becomes pretty much immediately fertile again. So in general, exclusive breastfeeding is critical for early brain development when adequate nutrition, positive stimulation, and care can improve the neural development. Next slide. So now our baby has received breast milk in the first hour of life and has been exclusively breastfed until 5 months and 29 days, and is now turning 6 months old. And that is where we need to start complementary feeding, which refers to basically any food that is given additionally to breast milk. And there are some recommendations about that. So it's important that complementary feeding is introduced really at 6 months. Not earlier, because the intestine is not quite ripe yet to receive other foods before that age, but not later either, because otherwise the baby can become malnourished if it doesn't receive complementary feeding. The next issue is food frequency. Depending on the age and the breastfeeding status, the baby needs 2 to 4 times per day to eat semi-solid, like porridge type of food, and that is important. So you can't just stuff it all into one lunch because the stomach of the baby is still very small. The next point is dietary diversity. We talk about 8 food groups, and the baby needs to have received every day, every 24 hours, at least 4. So just to give you an example, if the baby in the last 24 hours has received breast milk plus maybe some rice with the yellow part of an egg and some fruit in some form, then that's already 4 groups, and that will be considered okay for dietary diversity. The next point is perceptive feeding. That relates to all the stuff that we do to make the baby eat. Those of you who have raised children know that it's not so easy. At the beginning, the baby spits it out and doesn't want it, and there's new taste and new texture, and you need a lot of patience and joy, actually, to be feeding your baby. And all of this interaction, the psychological interaction between the person who's giving the food and the baby, is called perceptive feeding. I do want to mention here that it's very important to take into consideration gender. It doesn't always have to be the mother, and it doesn't always have to be a woman who's giving complementary feeding. The next point is continued breastfeeding until 2 years. That is very important because particularly as we will see in emergency situations, but also in poverty situations, sometimes the breast milk is a very important source of protein for those children, and other factors that are present in the breast milk. So we promote prolonged breastfeeding. And the last one is about hygiene practices, particularly around the complementary feeding. Obviously, if the porridge is not prepared hygienically, it can become a source of infection. And so hygiene practices like hand washing, keeping utensils clean, using potable water are very important to make sure that the baby stays safe. Next slide. So just to repeat again, the 4 practices that we talk about are immediate breastfeeding, exclusive breastfeeding, prolonged breastfeeding until 2 years of age, and the timely and correct introduction of complementary feeding as of 6 months of age. So now I'll go into the consequences of what happens when we have a problem. Next slide. So the inadequate feeding practices can be several. We can have a late initiation of breastfeeding instead of at the first hour, as I was showing to you. Some babies are fed for the first time, maybe on day 2 or 3. Oftentimes, breastfeeding is non-exclusive. They add water, they add tea or juices or anything else, or Coca-Cola and coffee, and which we have there. And then the bigger babies, the ones that are 6 to 24 months, sorry for that lack of translation, can either have a late introduction of solid food. So the baby is already 8 months old and is still not eating. Sometimes we have problems with the dietary diversity. They only give them one thing, something like rice. We can have a low meal frequency, which I was already mentioning. The stomach is actually too small to be fed only once a day. Or we can even have a problem with low food quantity, although that is rarely the case because the quantities are actually not so big. So what are the consequences of all these inadequate feeding practices? We get infection and malnutrition. And among the problems, we can have acute malnutrition, which is also called wasting or low weight for height. We can have in other children chronic malnutrition, which is also called stunting or low height for age. And we can have in any of those kids micronutrient deficiencies. We've talked a little bit about micronutrient deficiencies in the last webinar for the chapter of maternal nutrition, so I won't go into all these details, but we're mostly concerned about iron deficiency, vitamin A deficiency, and zinc deficiency. Now, all of these problems lead us to a higher risk of illness and death. But those who survive have also a slower brain development. And that leads, when they go to school, to a lower educational achievement. These kids cannot concentrate as well, and they can't learn as quickly as those who are well nourished. And on the long term, when these kids grow up, they have a higher chance of having actually overweight, compensating the lack of nutrition that they had when they were children. And that leads to chronic diseases later in life, as you all know, diabetes type 2 and hypertension among the most important ones. Now, in a sort of broader perspective, as a country, all these malnutrition problems have a negative impact on the economy and the social welfare of the entire country. Next slide. We're going to show you some images to what I was just mentioning. So the first image, you can see a tomography scan, CT scan. On the left side is a baby that is not well developed, his brain, and the right one is normal. You can just basically see that the not so developed brain is just full of water. You know, all these black spaces are water, whereas the normal brain shows as whiter. And then in the image down below, you can see neuron connections, or what we call synapses. The first one is from an undernourished child who died, and they were able to obtain this image. And the second one is from a well-nourished child, the same age, who also accidentally died. And you can see that the well-nourished child has loads of more neuronal connections. So we don't develop more neurons, almost not. But we do develop more connections as we grow. And when we don't have enough nourishment and nutrients, that just doesn't happen as quickly. In the photo of the woman who is measuring her child with a MUAC strip, you can see that the MUAC strip is red, but you can also see that the bones are sticking out of the kid, of her little daughter, and that is an image of acute malnutrition. We'll talk about much more about acute malnutrition in the next week's webinar. In the picture below that, you see two children. Actually, the taller girl is only 30 months old, and the smaller girl is 3 months older, yet she's much smaller. And that is chronic malnutrition or stunted growth, whereas, as I said, the taller girl has the normal height for her age. And then on the right side, you can see some of the consequences of micronutrient deficiency. In one, you have a bite-toe spot as a sign of vitamin A deficiency. And the pictures below show goiter and cretinism, which are iodine deficiency disorder, which we talked about last week. Next slide. So again, just to say that all of these consequences of inadequate feeding practices, the infection and malnutrition, acute, chronic, and micronutrient deficiencies are really preventable. That is the main message. We don't have to cross our hands and just sort of wait and see what happens to our population. Next slide. So now move into the impact of emergencies on infant and young child feeding practices. Next slide. A bit of this will be repeating from last week's webinar. So when we talk about emergencies, we talk about disasters that may be of natural origin, but lead to displacement or conflict. And typically we have a combination of both. So people are forced to displace and live in unhealthy conditions. And they are unhealthy conditions because they are losing their livelihoods. And if they were agricultural population, they may be losing their crops. They will have limited access to food, limited access to health services, limited access to water, particularly potable drinking water with a high quality, sometimes their basic services are interrupted, such as electricity or energy for cooking. They will have bad hygiene and bad sanitation conditions. And all of that increases diarrhea and other infectious diseases. So these conditions are the ones that give a risk or an impediment to practice good infant and young child feeding. And that again leads to malnutrition. Next slide. So what are the particular challenges for breastfeeding mothers? We're just mentioning 3 here, but there's some others. Very commonly, we find a false idea and worry among mothers, but also among their family members, that the stress and lack of food during the emergency is affecting her milk production. Just to remind us all, nature is cruel and everything goes to the baby. Okay, so the mother, if she's not eating, she will get very slim, but her milk will still be basically full of the nutrients that she had stored in her body. And that's because in nature, the young generation is always favored over the old ones. Also, the issue about stress, additional stress can be that the mother is actually separated from family members, or that even the baby is, or the children are separated from their parents. Another problem that we find very often in emergencies is the donation of formula or powdered milk. We'll go into that a little bit in more detail when we talk about the interventions, but it is a problem. And a third problem is that the mothers and the family members often have a lack of knowledge about the risks of using breast milk substitutes. So a lot of people think, oh, you know, there's an emergency, let's give some milk because all these poor babies are going to be malnourished. We'll go a little bit more into detail in the next slide. So what can we say about formula or powdered milk donations? Breast milk substitutes, or BMS, are not sterile. Most of them come in powdered form and need to be diluted. They do not contain the antibodies that breast milk has, so they don't provide any protection against infections. There is often an inadequate cleaning of the utensils, particularly the bottles. Bottles by themselves are a source of infection, especially the rubber part. As I said, there is a lack of water, or people may have water, but the water is contaminated. And so that contamination, particularly bacterial contamination, gets into the breast milk substitute. And finally, the breast milk substitute is oftentimes interrupted. At the beginning, there are many donations, and then as the emergency goes on, donations are not given anymore, or the woman doesn't have access to them anymore. So it becomes interrupted. We have a picture here of donations during the Mexico 2017 earthquake. But basically, any of the major emergencies, we can show you pictures of breast milk substitute or powdered milk donations. Next slide. So additional to the risks that I already mentioned, breast milk substitutes are often expired. They're actually not good quality. They may also be inadequate for the age of the baby. So for 0 to 6 months, it should be a different formula than to the older children. And oftentimes it's not the correct one. And they may also be labeled in a foreign language, which the mother doesn't understand and therefore doesn't know how to prepare, how much water to put into and how much powder. So as a consequence, on the short term, we will have interruption of breastfeeding to that child. And on the long term, mothers and babies become breast milk substitute dependent because her body will not produce the breast milk anymore because she started to bottle feed because there's no suckling of the baby. And also the baby is already filled up basically with that breast milk substitute, so it's not so hungry anymore and it doesn't suckle enough. So her milk will actually be reduced. And after after the donation stops, she oftentimes cannot buy those types of breast milk substitute. Next slide. So, in conclusion, non-breastfed children are extremely vulnerable and have a higher likelihood of getting an infection, becoming malnourished, and getting seriously ill or die as a combination of those two. On the other hand, the large quantities of infant formula are not needed, and an uncontrolled distribution of breast milk substitute can actually affect breastfeeding and increase the risk of illness and death. And this is very well demonstrated. So many people who respond to emergencies want to do something good, and they say, "Oh, I can buy some milk formula for the children and somehow get it to the emergency," and they can actually do so much harm that more children are actually dying than could have been if we didn't get the donation. Next slide. So I hope I'm preaching to the convinced already. Breastfeeding saves lives. It is more important than ever during the emergency. It is actually critical because, among other things that I've already talked about, breast milk is always at the correct temperature. It doesn't need any preparation. It contains antibodies which protect children from diseases, infections, and death. And it is the safest, most nutritious and accessible food for infants and small children. Next slide. I will now hand over to my colleague Yvette, who will take you through the interventions to improve or prevent infant and young child malnutrition. And if you have questions, please post them in the question and answer box, not in the chat box.
Perfect. Thank you very much, Caroline. Okay, so now we'll present the interventions to prevent infant and young child malnutrition with a focus of children under 5, but also children under 2, who are the most vulnerable. And I just want to say that what we're presenting in this specific webinar could have been presented in a week or even 2 weeks. There is a lot of information. We're not going into detail. So we're really going on the surface on many topics. However, we are providing a list of resources at the end of the presentation, and you will get the PDF of the presentation. So for you to have a look at these resources, to go more into them and learn more about the topic. Okay. So we should take into account that we're intervening to prevent infant and young child malnutrition, that we are still in the COVID-19 context. So we need to take infection prevention and control measures, including hand hygiene, personal protection equipment, such as the use of masks, eye protection, and long sleeve and clean go and gloves. We need to practice respiratory hygiene, cleaning and disinfecting equipment and surfaces, and manage supply chains adequately. So one of the first and also most important interventions is to issue a declaration to protect infant and young child feeding in the emergency. And that should include key messages for donors, local partners, and also the media to discourage formula milk donations, and also will foster other types of contributions, such as financial contribution. So the idea is really to that everyone really knows about the vulnerability of children under 2, their specific needs, and the risks they're going to, and also how donors and local communities can help them. So this is the first intervention. Oh, I forgot to mention, you will see throughout the presentation a small green book. That means that at the end of the presentation, you will have the full resource for you to go into more detail. Another important activity is a rapid assessment at the community level. So the idea is really to, for example, if you are in a migrant shelter at the border, is really to have a sense of the number of children under 2 that are there, and also to evaluate the contexts. Is there infant formula available and being used? Are there visible signs of malnutrition? Are there breastfeeding difficulties? We're gonna look more into detail in the next slide how to evaluate that. And also, is there available support? For example, are there other breastfeeding women or women with breastfeeding experience, healthcare workers that can support the mothers? So the idea to do this assessment is to determine the level of support needed. So how many children need support, but also how many, the number of qualified staff and trained staff we need to respond to this. So this rapid assessment allows to plan and estimate the needs for the response. And there are several information sources. For example, you can go and do direct observation and assess these different elements, but you could also interview mothers, families, and also shelter administrators of workers. So there are resources, model questionnaires or adaptable questionnaires that you can use that are at the end of the presentation. Okay, so how to evaluate feeding practices to identify the support needed. So we are using here a flow diagram. Sorry. So we need to determine, of course, the age of the child, to assess the consumption, the intake of food and liquids received in the past 24 hours, and see if the child is breastfeeding. If yes, if there is any problem while breastfeeding, and if yes, it's important to evaluate the difficulties and support the mother to overcome this. And this may take several contacts with the mother. If not, it's important to also encourage the mother to continue breastfeeding, to inform her about the importance of breastfeeding, the many benefits, and of course also continue monitoring to make sure breastfeeding is going well. If not, if the child is not being breastfed, we need to evaluate, has the child been ever breastfed, or can he suckle? And then see if relactation is possible, meaning that the mother stopped breastfeeding, if she's willing to restart breastfeeding. If the mother is willing to restart breastfeeding, then we need to support relactation. If not, another possibility to explore is if we can obtain breast milk or breastfeeding from another woman. This may not be culturally acceptable in all the countries, in all the contexts, but it's worth exploring. If yes, it's important to support the wet nurse, so the mother of the woman who's breastfeeding. And if not, it's important also to evaluate if there's a breast milk bank available, if there's, to give breast milk. And the idea would be to use donated breast milk. And if not, so then we can recommend infant formula. But to recommend infant formula, there are important criteria to take into account. So in this diagram, there is a lot of information, but the idea is that we need to explore other different alternatives to breastfeeding so that the child receives breast milk first and before infant formula. So, so breastfeeding support, one important activity or intervention is to establish private and safe spaces for breastfeeding. This is where mothers are provided with support from a qualified and trained health personnel. A very important aspect is to provide psychosocial support. In migration contexts, we have seen that mothers are detached, or the attachment is not very strong with their kids, because they report feeling that they may die, so they don't want to get attached to them. So you will see these women are going through a very difficult situation, leaving their country, maybe walking kilometers with their children. So all this, they have a lot of stress emotionally. It's draining. So it's really important to provide them with the psychosocial support as part of the breastfeeding support. In addition to that, it's of course important to focus on specifics of breastfeeding, such as the position and attachment to the breast, and also to strengthen their self-efficacy, self-confidence about being able to breastfeed despite the situation they're living. And having a private space for mothers to breastfeed can reduce isolation. Mothers can be with other mothers in the same situation who can give support, but we need to be careful because this may not be possible now within the COVID-19 context. So we need to be careful about that. So again, here with psychosocial and nutrition support, almost all mothers can breastfeed, including in emergency situations. So it's important to increase access to counseling for caregivers, all caregivers of children under 2, by trained health personnel or community workers. And these workers can use technology. This is one of the adaptations of this nutrition intervention of counseling, to use a tablet or a smartphone to show videos or images of breastfeeding. And here we can see an image of a breastfeeding counseling in Panama using the technology. So you might say, okay, but where can I find all these videos to support mothers? So there are many. We are providing you with the link. So there are videos available in different languages to download. Sometimes in a migration context, you may find, that migrants do not speak the local language. So in this webpage, you can find videos in different languages targeting mothers, such as positions to breastfeed, how to increase the breast milk supply. And there are also other videos more specifically on difficulties faced while breastfeeding. Another possibility is, of course, to do it with printed material, as we can see here. And here we can see, of course, the separation of 2 meters. Oh, I don't know if it's 2 meters, but at least some space between the counselor and the family. And the counseling, the important way here is that it's a one-to-one interaction with a 2-way communication. So this is a counseling session. Is not about the counselor just providing key messages. It's really about having a conversation with the mother, with the family, about how they feel about breastfeeding or complementary feeding, and what are the barriers, and also look at what are the concerns of the family and reply to them. Okay, now support to non-breastfed children. So this is a very big topic that we could have taken a week to only talk about this specific topic, but we are giving you the basics here. So here we can see an image of a mother feeding her child with a cup. So this is the way it is recommended, or a small glass, like here. The idea is that other types of of baby bottles are not really hygienic. It's really difficult to have hygienic measures with when bottle feeding in emergencies. And concerning the recommended breast milk substitute, the first option is ready-to-use infant formula. This is a formula that is, as the name says, really ready to use. You don't need to dilute or to include or to mix with water or anything. It's ready to use. So it's the safest option. The second option is, of course, powdered infant formula, but here you have more risks of dilution. So putting too much water into a small quantity of infant formula. And also, infection through the use of inadequate water. So, there are also milks that are not recommended, such as concentrated liquid formula, because then you need to also mix it with water. We also don't recommend use therapeutic milks. These are used to treat children with acute malnutrition. And also any follow-up infant formula or any formula targeted for children, older children, is not recommended. And also important aspects to take into consideration is that when supporting non-breastfed children, it's really important before buying any infant formula or preparing all the programming is to assess the need for breast milk substitutes. So really to understand how many children need infant formula. And then the recommendation is to procure breast milk substitutes, so not to accept donations, because these may be not the right type that is needed. So it's important to procure breast milk substitutes as well as utensils for preparation and feeding. Other important aspects to take into account is storage of breast milk substitutes. It's important to have a discrete storage so that breastfeeding mothers don't see it and instinctively would like to receive some. Another important aspect to take into account is distribution, how to distribute it while protecting breastfeeding. Again, here we can have two different private spaces for feeding, one to support breastfeeding women, and the other to support non-breastfed children. A very important aspect is to provide skilled individual support. So any personnel providing support to these families or mothers need to be adequately trained so that they can provide the correct and adequate support. And it's also important to monitor the use of breast milk substitutes. So here, I'm giving a summary of the main elements that are needed to use powdered infant formula. So the idea is that this replacement of breast milk is acceptable by the family. It is sustainable. That is that the supply is there for as long as the child needs it. It is affordable. The family can easily access it. Of course, if it should be feasible, the mother has to have access to all the clean and safe water and cleaning utensils to prepare feeds, and also the knowledge to prepare and feed, and of course safe, following all the hygiene elements. So you see here, it's important to have support from skilled personnel, hand washing, safe water, utensils, and also fuel to boil the water. Okay, now let's move to complementary feeding. So feeding children over 6 months of age. So the idea is also to assess the intake of foods and liquids received in the last 24 hours, and assess if the baby is receiving solid foods. If yes, we need to evaluate if the baby is receiving foods in an adequate frequency per day, and also the minimum food groups, which is unlikely in general in emergency situations. So here we should evaluate the barrier. So in order to address them. And an important aspect is to advocate for adequate food for babies. So it's not to advocate for baby food or industrial baby food. It's not that. It's really to advocate for a diversity of foods for children. As Caroline said, diversity is really important, is a key aspect of feeding children over 6 months. And it's also important to support the mother about how to prepare complementary food, how to feed, how, and also where to store. This will also depend on the context. There are all contexts in migration where the mother and the families do not have any control of the food being prepared. It can be whether the army or any other institution. So this is also where it's important as a nutrition sector, as nutritionists, to advocate for availability of adequate food for children 6 to 23 months. And if this is not possible, so then we can provide multiple micronutrient powders. So the idea about this powder is that is to enrich, to fortify the food that is being provided to the child that may not be diversified enough. So to prevent micronutrient deficiencies. So to support complementary feeding, there are also several resources. So in this website, there are videos available in different languages that you can also download and use in a tablet, in an iPhone, or a screen. Now, there are different elements to support complementary feeding. I mean, the important elements are about, well, kitchen space, storage, responsible food preparation. These may be in emergencies, maybe the food security sector that looks into that. But the responsibility is to really provide the nutrition focus of it. So really advocate to have the diversity of foods young children need. Here I am presenting the micronutrient supplements I mentioned before. So these are meant to prevent micronutrient deficiencies, especially anemia. And the main target group is children 6 to 23 months, although it can also be provided to children 6 to 59 months, so children under 5, with the exception of children under 6 months. And the idea is to use one sachet and apply it to the food of the baby, and really mix it well so that there's no flavor, or that the baby cannot perceive any change and rejects it. And the idea is to give one sachet per day during 60 days. So here is a photo from Brazil, where the healthcare provider is counseling the mother in this case about the use of micronutrient supplements. And here we can find a picture of how to spread these powders on the food. Although here we see that, I mean, there's meat, there are beans, rice, so we can see here already a good diversity of foods. Another element, another important intervention is a supplementation with well, it's called LNS-based, lipid-based nutrient supplement. So it's a ready-to-use high-energy base based on lipids that we can use with children on the move. So children who are not staying at a specific shelter or at the border, but that are continuing walking to the next border. So the idea of providing this product is to prevent malnutrition when children do not have access to food or have irregular access to food. And so this product can be consumed directly from the envelope, from the sachet. So no cooking or dilution is needed. And well, of course, the product should not replace breastfeeding. And it's recommended that it is provided in 3 times, such as, during the day, a bit like the meals. Another important intervention is deworming. So deworming is recommended to reduce soil-transmitted health load. And so there are here some of the doses recommended based on the age of the child. And it's also important that the staff is trained on the Helmich maneuver as first aid for choking. And if you have questions on that, Caroline will be able to give you more details. Another very important intervention is to communicate about adequate infant and young child feeding practices in the context of COVID-19. For example, this is an example, but there are also other messages. The precautions that should be taken when breastfeeding when COVID-19 is suspected or confirmed. One of the key messages is that mothers and babies should not be separated, even if the mother has COVID-19. The breast milk has benefits that outweigh the potential risk of transmission. But it's also important that the mother follows hygienic measures, so they use the mask and also hand washing. And of course that the mother keeps physical distance to other people. Another possibility to communicate is to consider, of course, the use of technology, for example, of social media through WhatsApp or Facebook. We'll have to see, this depends on the context. Migrants and refugees may not have access to this, but again, it depends. And you can also use videos and images, and even create mother-to-mother support groups and group education sessions on WhatsApp. And while this is last but not least, it's also important to explore the possibility to integrate messages on infant and young child feeding into the emergency response of other sectors, so that these messages reach caregivers through different channels. So through the activities such as cash transfers and also activities of other sectors. So here it's also important to discuss with the responsible person of the other sectors. And now this is a slide to summarize the key activities that can be implemented at the different points in the migration transit. So at the border, in shelters, well, it's important to issue a statement to protect infant and young child feeding, to conduct a rapid assessment, to identify the children under 2 and their feeding practices, to set up safe spaces for breastfeeding. So depending on the interventions you will be implementing, you could have a space for breastfeeding and a space for non-breastfed children. You can also provide, of course, infant and young child counseling, advocate for diversified food for children over 6 months, micronutrient supplementation, deworming. An important aspect is also to monitor the nutritional status of children, for example, using middle of arm circumference tapes. But that it's a very, a topic on its own. So we're gonna look into that next week. And an important aspect is to communicate on adequate infant and young child feeding practices and the availability of health and nutrition services. And here, the services or the interventions can be provided through mobile clinics, for example. During the transit, it's of course more difficult to reach children. So the idea is to identify them at the border. And for those children on the move that will continue to the next country or to their destination, an important intervention will be to provide them with energy protein supplement for the estimated number of days until reaching a destination or the next border, or a place where they can get food, of course. And in host communities, it's important to communicate on available nutrition services to refugees and migrants, how and where to access them. Also to communicate about appropriate feeding practices, conduct nutrition counseling, deworming, micronutrient supplementation, and monitor nutritional states of children to identify malnourished children. Here in host communities, it may also be worthwhile to issue a statement to protect infant and young child feeding. And of course, we should take into account the COVID-19 context and advocate to prioritize the continuity of health and nutrition services for infants and young children. And another important element is to maintain uninterrupted the availability of essential nutrition supplies that we presented here. So, this is this was the core of the presentation. As I told before, this went a bit on the surface, not really going into the details, but we're providing you here some additional resources that you can consult and go more into detail. For example, here I'm presenting the joint statement on infant and young child feeding in emergencies. So it's a template that you can adapt and use in your country. And this is an example of the one issued in Honduras. Also, there are adaptable questionnaires to carry out a rapid evaluation at the community level. So an observation guide, a questionnaire for caregivers, and a questionnaire for key informants working in the emergency. So we can provide you with these ones after the webinar. There are also recommendations and counseling packages. So we're providing the link here of the resources, and that of course you can use. It's not only on breastfeeding, but also on complementary feeding. There's also this other resource from WHO. It is already a bit old, from 2009, but I continue promoting its use as it's really, it contains a lot of information and really, really useful information, such as how to conduct a counseling session and provide elements about communication, support skills, how to talk with the mother, and also provides more details, for example, of the appropriate foods for complementary feeding. There are also resources, so more videos on breastfeeding counseling, but in contrast with the other videos that were targeting women or caregivers, these videos target trained personnel. So these videos are meant to train people who will support mothers. And there are also videos on complementary feeding counseling. So how to train personnel to conduct or to support complementary feeding. We have also a guidance note to support non-breastfed children in emergencies that include considerations concerning donations, procurement, distribution, and use in humanitarian settings. Here we're providing a guideline on the use of multiple micronutrient powders for you to consult. Another important resource with a wealth of information targeting policymakers, decision makers, NGOs, UN agencies, is the operational guidance for emergency relief staff program managers on infant and young child feeding in emergencies. So here you will find detailed information on specific interventions to conduct in emergencies. And finally, here we have these are interim operational consideration for supporting infant and young child feeding in refugee and migrant transit settings. And these are the lessons learned from Europe. So thank you very much for your attention. So we're gonna go now to the post-webinar evaluation. Caroline, over to you.
Yes, thank you, Geraldine. Can you post the poll again? Even if you weren't able to take the first, the pre-test, just fill out the post-test. As I said, it's anonymous. We will not see who answers what. And I hope to give you 2 minutes. Very well done. So we've got 24 people have answered the poll, which is 80%. Yeah, I'll stop it here. And I will share the results and compare them to our pre-test. So health staff should distribute powdered milk to fight malnutrition. We came from 59% and have increased that to now 79%. The correct or expected answer was that that is false. I hope we gave you enough arguments against at least indiscriminated distribution of powdered milk in emergency situations. Immediate breastfeeding means breastfeeding in the first hour of life. That is very good learning. We were at 35% and are now at 83. Just to recapitulate that's the definition of immediate breastfeeding. Which of the following can be a consequence of the use of breast milk substitute? Well, we already had 100% in the pre-test and we're staying at 100%. Correct answer was greater risk of diarrhea. I'm just going to very quickly say that the breast milk by the use of breast milk substitutes tends to decrease. So we would have a lower production. We would have more anemia because the iron in breast milk substitutes isn't quite as absorbable. We'll have more time that the mother needs for the preparation of the breast milk, and we'll have a higher risk of developing childhood eczema, which is an allergic illness related sometimes to reaction to the cow milk protein that's in the breast milk substitutes. Nutrition counseling is always an individual interaction with a two-way communication. Has increased our correct answers from 53% to 79%. Well done. Just to remind us all that there is other types of nutritional communication. We can do mother support groups. We can do messages in a group of mothers. We can send them an image or a video by WhatsApp. We can do radio programming. Communication is very broad spectrum, but when we talk about counseling, we really refer to the individual interaction where the counsel person has the option to ask questions and tell about her experience. So the correct answer was true. I will now hand over to my colleague Geraldine for questions.
Thank you very much, Caroline, and thank you very much, both of you, Yvette and Caroline, for the presentation. They were very clear, and I guess that's why we do have clear and straightforward questions. So the first one is going to be for you, Caroline, in fact, because there are some people wondering in the first slide, when you speak about the 4 recommended practices, you mentioned 8 food groups. So can you tell the audience what are these 8 food groups? And also there are 2 questions around allergy at the moment of food diversification at 6 months and plus. So there is a very specific question about the whole egg, white versus yellow and whole. And there is also a question regarding some food practices in fisherman area. Is it possible to give fish to a baby after 6 months old? So I let you, Caroline, answer that, please.
Okay, so about the food groups, this is an international classification. And the person who asked the question said, well, this is kind of different from the way they classify in my country. I don't quite remember where she was from. But just to let you know that there's international groups that come together and give out all these guidances. But then national ministries of health may choose to either follow or have a different type of nutrition messages going on. So the international way that food groups are classified, and this is for infant and young child feeding, recommendations are the following 8. So it's breast milk, other dairies, any type of milk or yogurt or cheese or whatever, staples, which is like grains or tuberculous, like potatoes and so forth, pulses, which includes all types of beans and lentils, meat, any type of meat, eggs is an own group, and then the fruits and vegetables are divided into those that have vitamin A and other fruits and vegetables. So for example, mango, a bit of papaya would be considered a vitamin A containing fruit, whereas oranges, although they're also yellow and orange, as the name says, do not have a high concentration of vitamin A. So you would have to, when you examine that, you would have to look them up, the specifics. The question about food allergies is indeed becoming sort of more important as children are consuming more industrially produced food stuff. We're seeing more allergies. We're seeing allergies more to added flavors, added colors, other types of highly industrialized foods. But there is a lot of scare about allergies to naturally produced foods. There's not really that I know of, but maybe Alex Yelamo, who is also on this call, may have more information about that. I would just go by the way the baby reacts and try to avoid industrialized foods. So anything that has, anything that's a product that has more than 3 things on their label, just don't give it to the kid, because it's likely anything in that can produce an allergy. And try to stay with food stuff that you get in the market or ideally have produced in your garden. Alex, do you want to join into this discussion about food allergies?
Oops. Hi everyone. Thanks, Caroline. I would say in general that there is no, specifically on the egg question that we keep hearing in certain contexts, there is no general contraindication. No, so I would go along with what you said. I think let's look at case by case, but in general, eggs are highly recommended to be introduced in the diet of a child, likewise fish. So as a general public health recommendation, then we need to see the specific cases. But I'm very much aligned with your recommendation on commercially or industrialized products, no? That they may actually introduce other artificial ingredients that may cause, no, again, some reactions. Over.
Thank you, Alex. I guess, well, in your countries, what we see a lot is really the very early introduction of highly sugary sweetened drinks and beverages such as Coca-Cola, Fanta, and so forth. And so I think that problem is kind of like more prominent for the Latin American context than the issue of developing an egg allergy.
All right. Thank you for these very clear answers and the recommendation. Now I do have a question for Yvette about the rapid evaluation that you are mentioning. What do you measure exactly? Do you take anthropometric measurement with the child? Do you look at clinical signs? And do you have any template for these evaluations you are mentioning?
Yes, thank you, Geraldine. So the idea of this evaluation is really to to have like a snapshot of the situation. How many children are there? What are their feeding practices? So that we can identify how we can best support them. I mean, how many personnel we need and to support which practices. Support non-breastfed children or breastfeeding or complementary feeding. So it's really to guide programming. The idea with this rapid assessment is not to evaluate the nutritional status of children, because of course the deterioration of the nutritional situation may takes time. So the idea is really not to evaluate this, but really to evaluate the whole situation. For programming purposes. You could also have a survey to measure more to identify the nutritional status of children, but this should not be done at that specific moment, at the beginning. This can be done after, to see the impact of the emergency. And yes, we have templates. We have templates in English. This can be adapted to your context. So with specific questions or specific elements to look at. And at the end of these questionnaires or template, you have a section how to interpret the finding of each specific question. So we will provide these. We will share these resources with you.
Okay, super. Thank you, Yvette. Now back to Caroline, probably for this one. Do you have any recommendation for a mother that is COVID positive? And also, do you know any official recommendation regarding mothers that want to be vaccinated and then that while she's still breastfeeding?
Yeah, right. The recommendations internationally are actually very clear. There is no recommendation to stop breastfeeding if a mother is COVID positive. There are certain recommendations about what she should do to avoid spreading the virus to her baby. The virus does not go through the breast milk. The only way she can infect her baby is through her hands or through coughing or sneezing, while she's obviously very close to the baby when she's breastfeeding, which is why it is recommended that she would use a mask or face covering and a very correct hand hygiene, really fulfill, like every time she's taking up the baby, she should have washed her hands for 20 seconds with soap or rubbed with an alcohol-based disinfectant. And now in terms of the vaccination, there is no evidence at all to recommend to stop breastfeeding either. So a woman who has gotten any of the currently available COVID-19 vaccines can continue to breastfeed. There are studies, I think, underway, but nothing has been shown that the vaccine either goes into the breast milk or alters the breast milk production or the flavor. So she can just breastfeed as she's been doing.
Okay, super, very clear. So Alex just sent us a message completing the discussion about allergy, and he's saying that the only thing that really need to be taken into consideration, it's ONE not to be given to children up to 1 year old to avoid the risk of botulism. So that's that was a complement to the answer given earlier. So now I will take one last question, and that's probably for both of you, actually, Caroline and Yvette, and it's around the myth of acceptance of these new products, acceptance of this new recommendation of practices, and myths at community level, but also at practitioner level. Because the question that one participant asked is about doctors. Like when they are convinced the mother has to take breast milk substitute because she doesn't have milk or the child is not suckling, etc. How do you fight this myth?
Maybe I can start. So of course, there are many myths around, infant formula breastfeeding, and I think the best way to address it is through training. You may also find medical doctors with outdated knowledge about infant and initial feeding. So I think training is the first recommendation, no? In this case. But also we should take into account that there are acceptable medical reasons for use breast milk substitutes, such as, for example, infants with a very low birth weight, so below 1,500 grams. There's a document from WHO that goes into the infant conditions and maternal conditions that that support the use of breast milk substitutes, at least for a period of time.
Thank you. Caroline, do you want to complement on the myth?
Well, it's always kind of difficult. I'm a medical doctor myself, and just to tell you, when I started medicine, I was in the internship. I had my pediatric teacher was telling everybody, mothers, to give lemon juice and tomato juice starting 4 weeks of age. And that was because he had studied in Mexico. And at that time, many years ago, people were worried about the vitamin C deficiency, because somebody had published something about that vitamin C is actually quite low in breast milk. So he was teaching that to everybody. And of course, nowadays we would say, oh my goodness, allergies all over the place, So just to sort of, there are many myths, and you will find doctors who will recommend things that are not recommended anymore. And that's because sometimes we don't keep up reading. So, and science evolves. So on the one hand, I would invite you as public health and public nutrition practitioners, you have a responsibility to keep up your reading, because when you talk to the public, you have to know what's kind of the latest. But when you talk about individual practitioners, just be kind and recognize that some people, just stay practicing what they've been taught when they were students. So, yeah, that's my answer.
Yeah, the refreshing knowledge, it's not commonly done across all practitioners. It's true. But yes, okay, thank you very much for this Q&A session. Thank you all participants for asking this very interesting question. And now I will hand it over back to Yvette for the closing.
Yes, thank you very much to all the participants for having participated and stay with us until the end. So we hope this webinar was very useful. We invite you to take the evaluation of the webinar so that we can improve our next series of webinar on how to best address your specific needs. And we will be sharing with you, the different resources and the presentation, and of course, the link to the recording. And we invite you to be part also of this webinar next week at the same time on the nutrition care of children with acute malnutrition. Caroline, do you want to say anything else?
No, just thank you for everybody, and have a great week. Bye.
Thank you. Goodbye.